Welcome everyone to today's installment of the EMS Interoperability Task Force call. I'm Josh Legler. Thank you for your time today. It looks like we're a little bit smaller group today, 16 of us so far, but got some great stuff to cover in today's agenda. Let me get my screen sharing on and we'll jump in. All right, so just as a reminder, this meeting is being recorded and will be posted on the NEMSIS YouTube channel. If there's anything you need taken out of the recording after this call, you can let us know. And we would like to take a kind of a moderated approach to the call. So make use of the raised hand feature in Zoom. You're also welcome to use the chat. I do want to try to make sure that we can keep chat conversations in sync with the verbal conversation that's going on so that we don't run two meetings at the same time. So appreciate your help with that. So let's first of all kind of orient ourselves in our overall process here. We've been meeting monthly. We've taken care of a lot of topics this year. And we are now in the section where we're talking about the specific standards and profiles to use in the interoperability workflow between EMS and the rest of the healthcare system. So today's call is going to be looking at the standards and profiles that are used to get hospital outcome data back to EMS after the patient encounter. I want you to take a look at what's coming up in the subsequent call topics, because I'm sure there will be things that will come up today that I may chime in and say, we're going to talk about that. We're going to talk about it later. So next month, we're going to talk about how EMS gets the patient medical history while they're responding to the patient and the standards and profiles used there. If you have specific experience in that area, then I would love to hear from you between now and our next call so that I can have you on the agenda and share your experiences. Then the topics that we still have yet to cover that we will get to. One is patient identification and matching. Based on this call, I've moved that up a little bit on the agenda to get to it earlier. So we'll probably get to that in November. Then data elements to be parsed and shared. So that may take multiple calls. That's where we're really going to get a little more clinical in our perspectives and say, what is it that EMS needs to see from the data that's available? What is it the hospital staff need to see from the data that's available? And then talking about APIs, the standards used for the actual messaging of the data. In today's call, we're talking more about the content standards. So subsequent calls will have October 12th and November 9th. And then I've struck through December 14th because the ONC annual meeting is on December 14th and 15th. And we're going to do an EMS data summit on the 15th. I want to give you just a little bit of a preview of what we're looking at for that. So the ONC annual meeting will be held in Washington, D.C. Registration for that is free. Registration is available now. The agenda is not available yet, but you can follow that first QR code to get to the registration. And Lisa, if you would put that link in the chat too, that'd be great. And then the EMS Data Summit is going to be the afternoon of the second day of the ONC annual meeting. So the ONC annual meeting will wrap up at about noon. And then in that same venue, we will have 3.5 hours for the EMS Data Summit that afternoon. So if you're there in person, then just plan on extending your stay long enough to be there for the Data Summit. If you're not attending the ONC annual meeting, that's okay. You can register for the EMS Data Summit to attend online, and we'll have an online option for that. Here's roughly what we're looking at for the EMS Data Summit. We'll pick up with lessons learned from the 2020 EMS Data Summit, the one that was held about 6 weeks before COVID shut everything down, and focus on improving integration of standardized EMS data with hospital data and information exchanges or networks. We're going to get perspectives from pre-hospital, from hospital, and the federal government perspective. I think what's going to boil up in this particular summit is, with the task force, we've tried to stay more on the technical side, make sure that we're understanding what software developers need to do to build their systems to make this all work. But we've identified a lot of stuff that's more policy related. And so I think that this EMS Data Summit will be a great venue for us to figure out some of the policy side, or at least figure out what tables we need to be sitting at and who should be at those tables to represent the EMS perspective in interoperability. So that's what we've got coming up in December. Any questions on the ONC annual meeting and the EMS Data Summit, or recommendations or input that any of you would have for what we should cover in that summit? Okay. If things come up, just send me an email. Let's jump into today's topic. So looking at the standards and profiles to use in the step in the EMS interoperability workflow where we get hospital outcome data going to the EMS provider after the patient encounter has happened. Here's the questions I'm hoping that we can answer today. What standards and profiles are used for that phase of the interoperability workflow? What resources are needed to help software to transform that data into NEMSIS format so that it can go to state and national databases? And are there barriers that are disrupting that outcome flow? Just to orient you from the high-level perspective, here's our high-level paramedicine care flow diagram. And the part I've outlined here is what we're going to be looking at today. So this is after the end of the EMS call, and the patient has been discharged from the hospital, and now we need to get that discharge summary back to EMS, and we need to include that outcome data in the data that goes up to the state EMS database. Drilling into that in the more detailed paramedicine care flow, I know this is pretty tiny, but there are some things listed here in the paramedicine care flow. So we have the IHE profile for XDS, which is cross-domain or cross-enterprise document sharing. MS is a medical summary, and there's a discharge summary option in there. We also have the consolidated CDA standard from HL7, and there's a discharge summary document in that standard. So that's what's been identified so far in here. This sequence diagram also goes down into a subscribe versus a polling approach. So subscribe would say, hey, when you get outcomes for this patient, then send them to me or notify me. And the second is just every so often the EMS system would need to submit a query that says, hey, do you have outcomes for this patient yet? And if not, you wait a little longer and query until you get something. Then you would retrieve the discharge summary and get some data elements out of it and incorporate those outcome elements into the NEMSIS XML data export that would go up to the state database. So that's what we're looking at in the overall flow. I just realized one thing I forgot to mention. We don't have Amit Trivedi with us today from IHE. He's traveling to the HIMSS Asia Pacific conference today. So we're going to miss him, but I'll do my best to keep tabs on the chat, and Lisa's going to help out with that too. Okay, so these standards are identified in that workflow diagram, the cross-enterprise sharing of medical summaries, the consolidated CDA, and then we also know about HL7 version 2 ADT messages, and it seems like those are very common today. So we're going to hear from a few of you about what standards are being used today, and then maybe what we should be looking forward to in the future as well. Okay, with that, got a few people tagged for discussion today to provide their perspectives. We're going to go to Matt Becker at No2, then over to Steve Rotman from WISHIN, then to Neil Thorne from RWJ Barnabas Health, along with the people from Zoll. I've also listed San Diego Health Connect and Texas Health Services Administration. Both of them ended up having conflicts and weren't able to make it to the call today, but have shared some written information with me. So I'll share what they wrote up kind of on their behalf. So again, looking at this question of the hospital outcome data coming back to EMS, what are the standards being used today? What are the standards we might be looking to use in the future? And what challenges do we run into that we need to address? Okay, so I'll stop my share, and Matt, I'll turn it over to you first.
Thanks, Josh. Appreciate it. And thanks, everyone, for the opportunity. Just want to share my screen real quick and let me know when you can see it.
Looks good.
So, thank you. So a lot of how No2 views outcomes data specifically comes from a lot of experience on what we've worked with you all in EMS on the past. So I do want to give a little bit of background on that so we can jump into how those lessons kind of pushed us in the outcomes data and specifically to what standards and what frameworks we use for that. Our connectivity strategy from the beginning has been very standards-based. It's been off of what can work at scale and what can get you the breadth and depth of information that you need so that you don't have to reinvent the wheel every time we want to bring on a fire department onto No2 or into interoperability in general. And so that really bleeds into our history of EMS support, which is to support most of those use cases, to use the frameworks that are in operation today, and really not just expose EMS to those frameworks, but really push for what EMS specifically needs. And we can get into what we're doing with that with outcomes as well to give advice in the future too. But we did do a lot of work with not just care quality, but TEFCA, direct, et cetera, to make sure that EMS workflows were considered, and we continue to do that into the future. And then you'll note there that we're trying to get outcome support into broader data policies and broader mandatory data policies in the future, which we feel is a pretty big step forward if we can get that to happen. So moving specifically into outcomes data, it is part of our overall connectivity strategy. We feel like once you're connected for treatment data, you should be getting outcomes data. Is that happening 100% of the time today? Absolutely not. But at the same time, that is a reciprocal relationship, and that's how it should work under HIPAA. And so we feel that should work at scale, and that's what we've been pushing. So we've been pushing a nationwide approach to this, really working with hospital systems and making it available to everybody once it's available to one system, making sure it's available to all. And so that we can get around things like folks telling us they don't have time or big hospital systems kind of pushing us to the side. We've taken on that approach of scale to make sure that it's worth it for everybody involved. The standards specifically, we'll go into in a little bit of detail here. We mainly use IHE and direct, and you'll notice very specifically the lack of HL7 V2 in the standards that I've listed, mainly because that is not how things scale at a national level today. If it comes to a future where HL7 V2 or even FHIR, hopefully, with some of the promises of TEFCA, will creep into a more scalable solution in the future, we're definitely open to that. But at the same time, it's a lot easier for the folks we're asking for the data if we're using the standards they're already using at scale today. So IHE and direct became the two big standards for that because that's baked right into the workflows that are happening today. It's easily available. There generally are a few switches they have to pull to make outcomes data available, but also within the data set, and Josh, you mentioned this in converting to NEMSIS data in your diagram so well, is the fact that you're not going to get a one-to-one correlation from the data you receive from hospitals. We're talking discharge summaries, patient-level CDAs. I can give you the exact document ID types if you want to get into that level. But what it really means is these are the same kind of things that they're sharing in terms of normal treatment, discharge, push type workflows to other hospitals today that they will be sharing, what we've seen shared in the outcomes that we have seen dispensed from hospitals to EMS systems. So there will be that translation required. Again, the trade-off there is that there is a scalability to it. You don't have to go ask Sutter and then go ask UCSD and then ask UCSF for data. The idea is once we bring one on, everybody plays by the same rules. And then pushing this from a framework level with the standards that are already in place today enables the same thing. The downside certainly is that you don't get to pick your own standard. You don't get to map it one-to-one to NEMSIS right away. But at the same time, it is a huge step forward in the little experience we have, getting that data back and enabling you to do your jobs better. And really, what I want to stress is next steps and feedback of, number one, if you have feedback for us or how we approach it, I'm certainly always available for that. But really just industry awareness. We feel like a lot of the time we need to scream as one big group instead of a bunch of little groups trying to do this on our own. I think this group is a big caveat in doing that. And we've done a great job of making sure that this is a priority for folks. We need to keep pushing that. The message is getting there, but it's not sunk in yet, as I'm sure you all have known. The other piece to it is the resistance we really get are bullets 2 and 3 of the ease of implementation and resource pushback. Again, it is making sure that it is as easy as possible and as cheerful as possible for the other side to give you that data, knowing their system, knowing how that's actually going to transmit data, and being able to work with them in a pretty cheap and cheerful way to make that happen has really been a benefit for us. And again, it's that one voice versus 10,000 little ones, where if you get 10,000 people poking at you, it's just going to be annoying. If it's one big group and we can do this together, we're going to be a lot better on the way to national outcomes data. That was the brief, quick, and dirty presentation. I'm interested in any feedback you all have, or else I can turn it back to you, Josh.
Yeah, so Matt, you mentioned using the IHE and direct messaging standards or profiles, not HL7v2.
Right.
So in national networks, then we're not seeing HL7v2 messages moving around. Those are more internal or could you explain?
I'd classify those more as point to point. So if you have a really close relationship with a particular hospital, I could see going down that route. It's just not a route we choose to go down because that's not the type of scale we're trying to provide. But if you really need that really integral and I'm looking for the word, but that really intimate, I need to deal with the exact pieces of data, that sort of thing at every given moment because your relationship with them is so tight, then yeah, that would be a possibility. But at the same time, you're still getting what you need, generally speaking, for outcomes data from these IAG and direct specifications, specifically with the documents that are being shared. And so it just doesn't become the benefits are definitely outweighed by the cost to trying to do that at any sort of scale, much less a national scale.
Okay, so the hospitals or the systems they use have already built the capability of providing these documents through a national network in HL7v3, or well, you said the IHE.
Yeah, essentially HL7v3 /
okay.
Yeah.
That would be what the IHE profile references.
Yep, it does.
Okay. Yeah. Okay. And then just to touch on FHIR, where is that in terms of national networks?
On the radar, we are still awaiting, and there's only so much I can say, especially since it's going to be public because of discussions with the ONC and recognized coordinating entity for TEFCA. But you will see FHIR in the future for TEFCA. That is the main starting point to where we will see this at scale nationally. I don't see any other network or framework, including care quality or direct, meeting that at scale in the near future. So that is where that is going. But at the same time, FHIR is something definitely on our radar. To my words earlier of cheap and cheerful, FHIR is definitely that. So that's where we want to be. We're just not there yet. And I want to set the expectation with this group that that's not a viable option if you want something at scale right now, at least in my opinion.
Okay, thanks. John Hodgson?
Yeah, hey guys, John Hodgson from ImageTrend. Matt, got a quick question for you. We had chatted here I don't know, a few weeks ago, maybe, about the work that you guys are doing with TEFCA in reviewing the standard operating procedures for
Right.
operations query. And you guys confirmed that you did get the exception approved within TEFCA as well for operations query for EMS to not have to be a responder.
So I do want to step back on that, John. The exception that exists today and that we're still finalizing in TEFCA, it's not final yet. It's not written down. So I do want to clarify that, just to be pedantic, but just be correct. It is specifically for EMS to not have to respond to queries, because that's part of the reciprocity. That's generally today used for treatment queries when somebody just arrives in a transport vehicle, or another type of treatment scenario like EMS in home or whatever. But at the same time, most of that data is transmitted through treatment purposes today. But yes, you don't have to respond with your own data because you have your own exception there. And we do expect that exception to carry through with TEFCA.
Okay, that's awesome. So the other thing that we were talking about is the possibility of creating some kind of an EMS, I don't know, profile or something that, a message coming from EMS would, receive priority, and especially if it's treatment query, but from an operations query standpoint, outlining these are the only things that we are asking for from an EMS standpoint. Any kind of news or updates or anything on progress there at all?
No, that generally takes a while because it has to be baked into the EMR. It has to be coded into the EMR. This is where I go into, again, what can we do right now versus what's in the future. We need to get to a place where outcomes data is its own fire resource, its own document type, et cetera, to be too simplistic with language. But we're just not there yet. And once we are there, we still need folks to implement it. And so that's going to be an additional step on top of that. That is something we're pushing hard. But at the same time, there's no immediate approval for it yet. So we're trying to work with what we have.
Okay. Awesome. Thanks, Matt.
Other questions or discussion for Matt?
Hey, Josh and Matt, this is Dane at No2 real quick.
Hey,
I think one clarification I'd just like to put on the table to make sure, because EMS can be both 911 and they can be in that role of community paramedicine, mobile integrated health. And the responder to a treatment query, Matt, just to be even splitting a further hair, if they're a community health, community paramedicine program, and they're doing patient visitation and they're charting those encounters, do those need to be responded to from a treatment query standpoint, or how does that work, the difference between 911 and community health?
So that's a great question, Dane. They maybe need to be responded to, and that is on a case-by-case basis. They would not qualify under the exception that I'm talking about to be initiator only. And so there's another exception in there if you don't have data inside an electronic medical record, that you're also excluded. And so it depends on how you're doing that documentation. So we generally work with folks in community medicine for that specifically and moving through that exception, but it is a maybe.
Yep. All right, perfect. Just want to make sure that I got on the table.
Yep, fair enough. Thanks, Dan, for that clarification.
And for future consideration, I want EMS as a community and software developers as well to be thinking about not needing that exception anymore in the future. What I mean is getting EMS fully integrated into the interactions, where if someone's primary care provider wants to see patients' recent healthcare interactions, and one of those was a 911 call for their diabetic emergency last week, that EMS responds to those queries. It's good. I think that exception allows EMS to come into the networks and get started on the ground floor. But from my perspective, it'd be great to see EMS continue to mature in its participation to where that's essentially no longer needed in the future.
Great point. Thanks, Josh.
Anything else for Matt?
John, you have your hand up?
Yeah, I got one more follow-up on that.
Yeah.
So, just kind of following up on what Dane had asked, I had a similar question about, as we're thinking more about community health, and that's becoming more of a thing folks are trying to take advantage of. Is there any stipulation that would preclude EMS from doing say a care quality lookup So they're gonna, they got it on the schedule to go see Miss Jones tomorrow, right? And in advance of that, can they go pull up that information on Miss Jones so that when they show up, they've got all that information and they're able to show up with a plan of what to do?
Yeah.
Or do they have to be in the middle of an incident before they can use it?
Yeah, generally a treatment relationship, and I'm not a lawyer, but I do study the HIPAA laws on this pretty closely. Generally, the HIPAA relationship is understood to be when the patient establishes a medical relationship with you for treatment, and that is not when you show up at the door. That is when you schedule the appointment. You're certainly empowered to do pre-charting. You're certainly empowered to get that data in advance to do prep on that patient. That is treating the patient. Is generally accepted under HIPAA, and it's what most actual major EMRs do in an ambulatory setting. Even if the patient is 7 days out from their appointment, they're going to have that query done in the background, those documents pulled, and so when a clinician enters the chart, even if it's days before that patient actually shows up, they're going to have the most up-to-date outside information. And I encourage you to do the same.
Awesome. Thank you, sir.
Cool. I've noted that also for our when we get to the topic about EMS getting patients' medical history at the beginning of a call, we can come back around to that one. Okay, great. Anything else? Okay, thanks, Matt. I think we're going to go next to Steve from WISHIN. If I understand correctly, Steve, you don't have any slides, but you got some information you can share with us about what you're currently doing to get hospital outcome to EMS in terms of what data standards and profiles you're utilizing for the hospital outcome data. You do have stuff to share.
I do have some slides, Josh. Yes.
All right, go for it.
All right, great. And I'll just get right into it. Our whole focus has been providers and vendors where they are today, where they could be. In the future is what we can develop, but for Milwaukee County, and specifically the City of Milwaukee Health, Fire Department, that does more runs than anybody in the state combined. We have partnered with them and ImageTrend to establish a bidirectional data flow. And this is using the SAFER model that we've been introduced to. WISHIN is, I'll step back, WISHIN is a statewide entity for health information exchange in Wisconsin. We have 120 plus hospitals and over 2,100 sites of care. Many EMS using for the purpose of billings collection, but naturally that has matured into bidirectional access of data for both on the hospital side and EMS side, and addressing those data needs locally where healthcare is being delivered locally. And so where we began is EMS data into WISHIN. That was the lowest hanging fruit. Started working with ImageTrend, I would say 3 years ago, where from ImageTrend, and we can establish these connections with others, but we started with ImageTrend, given that was City of Milwaukee's EPCR vendor. It starts with an HL7 ADT message establishing that relationship and encounter. And then when that run and documentation concludes, a CCDA is sent using IHE providing registry protocols. So typically that's 3 hours after the transport, and we're able to identify that because we receive real-time information by way of HL7 interfaces from all of our participating organizations, because we do want that real-time clinical information to support decision-making, care coordination in real time, regardless of where that patient went. And we aggregate that clinical information with this EMS data. So that the typical 3 hours is because there's other aspects of an EMS provider's job that has to happen before they conclude that documentation. I've said it here before, and I'll say it again, correct demographics is absolutely essential. And we are looking how to even shortcut that, even where the systems are disparate, where, again, we receive hospital encounter information in real time. An EMS provider can go into the system and clarify. I'll just use my own name, Rotman. Rotman could be Rodman and Rothman and all of those things all together, where an EMS provider looks up, who did I transport to Advocate Aurora, West Dallas, and at this date and time, and verify the demographic data, so that when I, as an EMS provider, submit the EPCR, it connects to that hospital encounter. So now a hospitalist or trauma nurse that has to do reporting can look up that encounter and have access to that EPCR. And in some cases, it's working, I would say, very flawlessly, but where those demographics don't match, we can't match them. So with the hospital data back to EMS, again, we're receiving hospital and encounter information, lab data, diagnoses, procedures, anybody on the care team. We're aggregating that by patient, not by provider organization, and combining all of the information that we have into a CCD that is available today in a web portal or in an automated way through a query and retrieve using IHE query and retrieve protocols. That's taken some time to do testing and validation so that entire flow works, and it now does. Now we're moving it to the next phase where, again, the EPCRs are sent to WISHIN, following that document done by a provider to exist in and attach to a hospital encounter, and then automating the query of that hospital outcome data back to Milwaukee Fire. So we are finalizing that last piece of functionality so that there's no mystery about who it is and what information. There's a closed loop, essentially, so those EMS providers have that data, not in real time, but essentially in real time. Future functionality also is to push EPCRs to hospitals. I'll point back to ditching the fax. There's EMS coordinators in hospitals that struggle with getting the EPCRs in an automated way. So that's what our focus will be in the here in the near future, and bringing in additional data from Milwaukee Fire and other EMS providers like EKGs. This is kind of the flow that we're working with. Again, nobody has to think about clicking a button or doing a query for information. We want to automate this cradle to grave. As soon as the EPCR is done, it's pushed to us. It's available to trauma nurses. Once all of the, and this is going to be time bound, once all of the outcome data is available, that data can be pushed back to EMS providers as a comprehensive hospital outcome report in a patient-centric CCD. And then in our current system, for those that want it in real time, they don't want to wait for the automated. This is a view of what our community health record looks like. Those documents, both EPCRs and outcome data, lives in either documents and or CCDs. So that's what I have to share. Happy to address any questions.
Thanks, Steve. So just to make sure I got it down right. So you're getting a patient level continuity of care document from the hospitals into WISHIN. Is that right?
Yeah, and it's just the CCD, all HL7 and CCD, parsing all of that information and creating a combined single document that's deduplicate.
Oh, okay. So is WISHIN doing that work of combining the data from various sources?
Yes.
Or is that okay?
Yep.
Okay, got it. And what is WISHIN getting from the hospitals?
Admit, discharge, transfer, so demographics, labs, insurance, our lab data, pathology, provider notes, surgical notes, plans of care, radiology reports. So it varies by organization, but in Wisconsin, there's a incentive to all hospitals to participate in WISHIN. And so we're really closing out the entire patient record across 166 hospitals.
Okay, so they're sending you a bunch of essentially HL7 V2 messages, and then you're compiling that into a CCD. Is that correct?
They're sending us, yes, HL7 V2 and the CCD V3. And we parse all that data together and join it into a single, what we're calling a super CCD.
Yeah. Okay, great. Anyone else have questions for Steve?
Yeah, hi, Steve. My name's Mike Spigner. I'm actually one of your neighbors at UW-Madison. We are currently working on sorting out a health information exchange with EMS and kind of going through all our options right now. And I suspect it'll be good for us to connect offline as well. I actually see John Hodgson in this call, who I talked to recently. My question is really about the patient linkage. It looks like you used a deterministic linkage. And as you said, the correct demographics are really essential to that. I'm curious, has your group looked into any kind of probabilistic linkages or anything like that? I only say that because in a recent discussion with ESO, it looks like they acquired some other company that focuses on probabilistic linkages, and their match rate is apparently very, very good. And obviously that increases your sample size, right? Because you're going to capture some of the ones with a little typo here or there, things like that.
Yes. I will say we are enhancing our entire infrastructure today, hopefully to be rolled out by the end of the year. And that master patient index and algorithms is, I would say, more probabilistic based on a set of required fields that can roll up to a count. And if that count exceeds a minimum, it'll roll up and create identities. If there's a potential, that's where human intervention is needed. So there's various levels, and we're testing and validating. That's really what's holding up our go live is MPI, making sure that any and all possibilities have some human eyes on it. But if we can, based on some determining factors, match those automatically with those probables, put some human intervention behind it, and get those matched or not matched. But what we're seeing on the EMS side, it varies so dramatically, even with patients that a previous relationship with, like 3 different identities, even in their own system, that we need to continue to work with them on data provenance and clean up that the demographics across, because then we can take on that ownership of identity management across all systems.
As a reminder, a couple months from now, we're going to get into the patient identification and matching topic, and dive into some details there. Other questions or discussion for Steve? All right, thanks, Steve. Let's turn it over to Neil Thorne at RWJ Barnabas Health, and he's going to talk about what they've got going on there. I believe you've got a hospital-based EMS, so that more of that tighter one-to-one relationship that Matt Becker was talking about. Neil, go ahead and show us what you've got in place there.
So thanks, Josh. Thanks for asking me to speak on this. So just kind of to give you an insight where we are at, just a little bit of background on our organization. As Josh said, we are a hospital-based EMS system with approximately 55 BLS, transport BLS units, 35 primarily non-transport ALS units, 7 critical care and 1 rotor wing aircraft, with 12 acute care hospitals across the state. So comparatively speaking, a fairly large system. We actually existed with an HL7 interface going back pre-2015. I stepped into management around that time. And that's where it was a single push from our registration system of initial registration information. And then it received an MDM link PDF document back to the hospital, share information within the hospital. Unfortunately, there was a lot of limitations based off of that single link, single push message information. In 2019, we initiated an evolution of that system as our organization has grown and our EMR platforms had changed. We looked to expand those connectivities with the long-term goal of importing all of our EMS records to the hospital EMR across multiple platforms, provide all demographic updates, and then to meet our state regulatory requirements for disposition diagnosis information into our EMR. Additionally, we were looking to also get more internal transfer information to be able to look at how we are doing our patient care to improve our clinical practice. So in our current state, what we work towards, we had to make linkages with Epic, Cerner, and Allscripts, Sunrise Clinical Manager. So we had to be able to make sure we could work with all the different systems. Where were hiccups, we work through the Rhapsody interface engine to transmit all of our messaging. And then for the PDF documents, for those that cannot accommodate the appropriate ADT types, we're using the Highland on-base system to be able to manage the document import. All that being said, we're doing this all through ADT messages. When we set this up, it was impressive at how quickly we're actually able to do the initial interface build using the ADT messages. Where we ran into slowdowns was more tied to our follow-up information mapping to the types of floors, tele, ICU, et cetera, as well as a decision for meeting the minimum necessary rules and how much information we were going to be sharing. So we ended up doing with our interface, and this is open to any EMS charts user. So the intent was to be able to get this information shared back to our EMS organizations and to be able to get their documents into our EMR to better our patient care. We're using AO1s, 2s, 3s, and 4s, 5, 6, and 8, with the AO2s being restricted to those patients that are being admitted with a documented type of ambulance. So that's kind of how we tried to restrict the information that's going across both in the number of messages and to meet those minimum necessary rules. Through that interface, we have a pretty robust element of information sharing that goes on. And we actually set up, so to take a step back, the other part of how we built this interface is all of our admit messages are going across so that we're not just being restricted to those patients who are coming in through the emergency room, but also to facilitate those patients who are going in between facilities. So if we have a critical care transport patient, aeromedical patient comes in, we're able to get that record into the hospital medical record as well, because it becomes important to their care additionally. So to facilitate that, that's where we found that balance point by all admit messages, and then to meet the state requirements, the discharges, and then the intermediary pieces were a little more restricted. Just as a sample of what we see currently. So from the administrator view, this is the screen that we end up being able to see. And from this perspective, it gives us a lot of information in the sense of it's our demographics, our insurance information, which helps with our billing components. And then it gives us the patient movement, our diagnosis codes. So we're able to interact with the system and really get a maximum amount of information provided to us, and to be able to really improve what we're doing with our patient care. And pardon me 1 second, I need to make one minor modification before I jump to the next slide. So, and then from the end user, so where we balance that point of what the employee can see for their improvement versus what's a slightly more restricted data set. This is what the crew ends up seeing. And this is accessible from the EMR directly in the chart where they did their documentation. And again, it's similar information, but a slightly more restricted data set. And we found that always room for improvement, but we're getting a decent balance of getting that information in and being able to share it. One of our current challenges, though, is the way we meet our NEMSIS requirements, both our NEMSIS requirements and our state regulatory requirements, to say our charts have to be available to the hospital, which is facilitated through the state data exchange within 24 hours. We export, and at that point in time when the chart's locked, whatever is available is for follow-up information is what goes to the state. The long term is to be able to improve that interface so that there's a secondary push to capture when we have those follow-up information available. But that's kind of one of our next works in progress. And just kind of a highlight of where we stand with our organization. These are 11 of our 12 acute care hospitals. The 12th hospital, which was a newer acquisition, is not on the system as of yet. And it gives you an insight over the monthly statistics up top is last month on the number of charts for patients we brought to the receiving hospital, how many are matched and what our percentages we're sitting at. And we're sitting at roughly about a 90% or just under a 90% match rate for our patient records. And then just as a snapshot also, we sit at roughly just under 1.8 million messages a month to consider with this large, decently sized population. So, do you have any questions about this?
So Neil, I wanted to touch on one thing that you and Steve both touched on, I think, which is that there's a variety of messages being generated by the hospitals. It's more than, we dropped off the patient and then a little while later we got their outcomes, right? Instead, you got an admit message, you got potentially a transfer message, you got a discharge, you got all these messages that flowed over a period of time. Eventually the patient was discharged, and I think the discharge one, is that where you're typically going to find their primary diagnosis that they had at the hospital?
I will have to defer to the Zoll team to know exactly which message it comes across in. I'm not 100% sure of that.
Okay.
Yeah, this is Mario from Zoll, and it can vary depending on EHR and how they have their workflows configured. But typically, the final diagnosis it varies a lot. The final diagnosis is often for emergency patients who come in. They spend half a day in the ER. And maybe sometime at inpatient or cath lab or something, it'll probably come in with the discharge itself, the discharge event, the discharge AET message will have it. Sometimes if it's a long-lasting patient that needs to stay in ICU for a number of weeks, we might already know the final diagnosis for that patient. We just don't know their final outcome yet because they haven't been discharged and they're sitting in an ICU. And to make it even more funny, because healthcare just does not want to be simple at all, hospitals have some time after discharge to have the quote unquote primary diagnosis that they use for billing purposes. So it might even change up to, in some cases, in theory, up to 20 days after discharge. Yeah, you heard me right. So it varies. That being said, typically we know the final diagnosis, and sometimes before or at discharge, and sometimes we can even get it before the patient's discharge. Right? Hey, that patient's still in ICU. Wow, but I know what their diagnosis was. I know exactly what kind of study that patient had. He just had an unfortunate outcome that he's still in ICU.
Yeah, so if they're still in the ICU and you got the diagnosis before they've been discharged, which message would that have come through, or which message type?
Oh wait, patient update.
Information update. Okay. And then if they finally got the diagnosis figured out for billing 15 days after they discharged the patient, another 08. Okay.
Yep.
Got it. So like if you get it in the discharge in A03, cool, but it might change later, or you might get it before the discharge, and those would all be in the A08s there.
Yeah. And this kind of goes back to, what Steve was describing. And Steve, I love the term, that as software like ours or Steve's is getting a series of these, because ADTs, they're just event notifications on what is happening in a patient encounter. And as we're getting those, we're both kind of doing the same thing. We're creating that quote unquote super CTD that over time is, hey, I don't have a discharge yet, but I know where the patient is. I know the patient went to the cath lab. I know the patient had this specific type of study. I know that they're in ICU. No idea when they're going to be discharged. No idea if they're going to survive, but at least we know that. And we're gradually over time building that through the ADT messaging.
Yeah, right. And so then if you come, from a NEMSIS perspective, where a NEMSIS patient care report is a summary from beginning to end of an EMS encounter, that's a very different kind of paradigm from what we see on the hospital side, where we get a series of messages updating the patient's status. They don't know. In EMS, typically, you're going to be with the patient for anywhere from a half hour to a couple hours, and then it's done. But in a hospital, of course, that varies widely. They could be in there for months, or they might just be in the ED for a couple hours. And so we can see why that paradigm is different, but that's an important thing you have to deal with to figure out how do you decide when you've got enough information to share back to EMS and say, here's what we learned.
Exactly, yeah. And that's some of the things we're looking at. I was shocked too a few months ago, Josh, when you said that there's only this small percentage of PCRs that the NEMSIS tech has that has outcomes data. And I quickly grabbed a spreadsheet and was doing, how many PCRs do we think Zoll sends? How many do we think we have outcomes? There's a problem here. The math just doesn't add up just if you think about us. And I think we started identifying, okay, this is what's happening at the state. This is that patient who is in the ICU for 3 weeks. Even though we got it, you may never get it.
Yeah, right. Because that outcome data eventually made it back into the agency's data system, but it didn't make it as an update out to the state and therefore up to national. Yeah.
I think if we have a minute, I don't want to take other folks' time, but what Neil described here, I think is very HL7B2 focused. And I think a couple of the presenters today, Steve talked about HL7, but a few others are going to be talking about CDA, and that's fine. We contributed to the standards. We're an early adopter. We continue to do a lot of the things that folks are talking about today, CCD, CDA, via an HIE using IHE protocols, via direct message. And I looked up the math, about 40% of the facilities that our software sends PCRs to electronically, ignore fax because we hate it, but 40% of those guys that are receiving it electronically are receiving it in that model and continue to do that. But early on, what we saw is we're just not getting good enough adoption and value. So we started taking an all of the above approach, and that's where we started looking at for V2. And even though a little bit more than half of our facilities, about 80% of our PCRs are being transmitted via V2 or are receiving outcomes via V2, And I think we all know the kind of the limitations, right? That you have a patient match problem. You have a problem when you get documents, big honking documents, but it's not discrete data that you can automate. You have things that people need to look through 5 pages for. And then there's either opt-in or opt-out laws that vary by state, and different consent models that are actually implemented. You know, it's one thing of what the consent model is in New York and New Jersey. It's a whole nother thing to say, well, this specific exchange, what have they implemented? Do we have an API where somebody can get that information in real time, or do they have to swivel chair into another application? So that's what V2 has helped us improve. I think that TEFCA and some of the things that are happening now with TEFCA and some of the standards that we're hoping to develop here will help improve that. But like Steve said, for right now, HL7V2 ADT is important in conjunction with good patient match. The access to discrete data allows us to build that super CCD without having to rely on a document, and allows us to further automate getting that PCR into the patient chart in the hospital and getting the outcomes back to EMS without manual steps and without having to read documents. There's limitations. You still need access to further documents to get things like, I want to look at their labs and their blood work and look at the procedure note that their surgeon wrote up. You still need access to further documents for that, and maybe FHIR will help. But that's what we found HL7V2 to be valuable.
Okay, thanks. Anyone else with questions or comments for Neil or Mario? Okay. All right. Over to San Diego Health Connect. Let me bring up just a document on my screen. Okay, so they sent over some just some notes that I could share with all of you about this question of what's being used to get outcome data from the hospital to EMS. So standards and profiles there, as we've seen before from the SAFER model, they're using HL7 V2 messages, and then they're mapping those into certain e-outcome elements in the NEMSIS data set. He had a few considerations here, which I think some of these we're going to come back to when we get to the topics where we decide exactly what data is clinically or operationally important from within these messages or standards that are being used. And so he had some notes on that. I think we'll get to these in a future call, but what does outcome ultimately mean? What important pieces of information are needed? Do we need to make any changes to NEMSIS to make a home for data elements that are not currently supported by NEMSIS that are outcome related? And which data sources would map into those elements if we did that? Resources that he said would be important to have would be standardized crosswalks or mappings, for example, going from CPT codes to ICD-10 PCS codes, and to have something standardized so there's not variation out there. Also, he mentioned with ICD-10 codes, a way to roll those up into a level of detail that's relevant to EMS and not too detailed. So we can certainly look at resources for ICD-10 roll-ups. And in terms of barriers, various repatriation methods for outcomes, in addition to returning outcomes to EMS data origination. Reporting could be a multi-hop flow with many points for breakdown. So I think we saw that from WISHIN and from RWJ Barnabas Health, that this patient spends a varying amount of time in the hospital portion of their care, and lots of stuff might happen over that period of time. So getting all of that kind of collected and turned into something that we would consider an outcome summary for EMS is one of the important hurdles. So I know they're not here to respond to any questions, but does anyone have any comment on the things they wrote up from the SAFER perspective? Okay. And then from Texas Health Services Administration, I had an email with Catherine Lusk, who is on a flight today, but I think there were a couple kind of takeaways from the information she shared with me. Consolidated CDA sounds like, that continuity of care document is probably the target standard for the hospital outcome data. And I think from what we saw today is even if it's HL7V2 messages that are flying around at the hospital level, then we have entities today that are collecting those and getting those transformed into a continuity of care document in HL7 CCDA. And then she mentioned direct secure messaging as the standard to use for the actual connections and transmission of that data. So we're going to look at that in a future task force call. Today we're kind of focusing on the data content standards. So that's what she was looking at, and she just emphasized, the more that we get everyone on the same standards, the better it can be for interoperability. Okay, so opening it up to all of you. I want to know if we have been able to answer today's questions of which standards and profiles are used for getting hospital outcomes to EMS, what resources are needed to help transform data into the NEMSIS format so that we can get those outcomes into the national database, and then what barriers are in the way. So let's see. Yeah. Just opening it up to all of you, did we answer these questions? Is there more that we need to dig into? Do you still have questions around this topic? Bill?
Hi, thanks everybody. Again, the least technical guy in the room here. But was a field provider and user of some of the outcome tools. The question I had, and I understand the limitations of it, but for our rural folks out there, they're looking for outcome data. Just that barrier or that potential disruption to data flow is when the event is associated specifically with the case. And those people that require that higher level of care that you need that outcome data on or want that outcome data on, such as the STEMIs, the strokes, and that, when they're transferred to tertiary facilities, you lose that linkage, right, between the case level detail at the local facility versus that longitudinal information once they're transferred to the other facility. I don't know if that is a nut that could be cracked or just something to think about.
Right. So you're talking about where agency A, which is probably a rural agency, takes a patient to a local hospital, which might be a community access hospital. They package the patient up and then they send them on to a higher level of care hospital somewhere. And agency A wants to know what was the outcome of my patient. Is that what you're talking about?
Yes.
Okay. Yeah. Anyone have comments, especially from those who presented today, on what is currently available or what might be available in the future for that agency to get outcomes, even though they're not coming from the hospital that they directly delivered the patient to?
I don't know if it's foresight, but prior to that question happening, I dropped in based on some of your feedback, Josh. WISHIN aggregates much more than hospital data. We get integrated or independent clinic information, corrections, FQHCs, behavioral health, mental health. I know I'm missing some. Free and charitable clinics, So regardless of where an individual seeks care, I mean, that's the power of what we're doing as a super CCD. Wherever they receive care, an EMS provider can essentially watch encounters or coordinations of care, planned and unplanned transitions happen in real time. And if they want that data, they can pull it in real time, or they can automate that through what I mentioned previously, a super CCDA. So that super CCDA can be a longitudinal. So wherever that patient has received care for any time period, it's not limited to an encounter CCD. Could be all of their data that could be relevant to outcome measures or value to the EMS. That is an approved use case for us. It might not be an approved use case for everybody else, but that's how we're allowing, well, not we, our participants are allowing their data to be used.
And I'm going to go a little off topic with a policy question here, I guess. So patient medical history, I think that's pretty clear. Patient EMS shows up at the scene of a patient, and they need to know some pertinent medical history. When we're talking about the outcomes phase, like we are today, they want to know what was the outcome, what was the diagnosis, and so on from this patient that I treated on this specific incident. So policy-wise, how is the decision made as to like how far in the future the EMS provider should be able to look? Because eventually that patient's going to have other medical encounters that are completely unrelated to the call that they had with EMS last week. Like, how does that addressed?
It could be related to the care they provide, though.
Mm-hmm.
So, yeah, and that's where our use cases may not align. We abide by HIPAA, privacy and security, but we're a little tighter. But the way provider organizations' data as designated record sets, their data is allowed to be used, and they are the decision makers of those policies, not WISHIN alone. That's where they have sovereignty over how that data can be used. And it's expanded. I'll say that from WISHIN's use cases, EMS started with billing, and then it expanded because hospitals, clinics understood that, well, especially in the community paramedic role, they need access to more than encounter-based outcomes. They need from a specific hospital encounter. They need the full visibility because they are boots on the ground provider on their behalf. So that's why the access has expanded.
Okay.
I think from a national framework example is I have the same answer as Steve, it's just in a different flavor. It really is the matter of both systems really agreeing to whether you're using the minimum necessary clause or something else, just agreeing to what that's going to be. In general, though, we see when records are faxed over, for example, if for these requests, a lot of time it can be the full patient's chart. It's just whatever happens to get faxed. And so interoperability with electronic standards tends to work the same way. You're given a list of choices of what you need, you pick what you need, and there's just a trust that everybody's following HIPAA in that regard too. And there's a chance you're going to need something from a prior encounter. There's a note that you need to see or something like that falls within HIPAA, and that's up to your own interpretation as well. And so there's tools within IHE and others to limit date ranges and stuff like that. And there's a lot of talk about hospitals wanting to do that. But at the end of the day, you have access to the patient's chart. And no matter where the patient's been seen subsequently or whatever, if you need it for outcomes data and it falls within HIPAA, it's generally your right to get that data. So we try to err on the side of making sure that folks can have access to that and then use their own judgment to make sure that both sides are happy with what their compliance departments are saying.
Yeah, okay, right. So that it's it becomes more of a policy only question, not a technical question. You're not trying to implement technical
Right. And generally,
restrictions.
yeah, the policy doesn't get in the way of the technical either, just to clarify that point. It does in a few cases, but at the same time, when we're talking about outcomes data specifically in that little subset of operations, it's generally an easier conversation. It's just really about the lift to get there. So again, your mileage may vary, but that's at least what we've seen.
Okay. And I have a question for everyone that's a little bit related to Bill's question in a way, and I'm going to flip up to this overview of the workflow. We focused on getting outcomes data back to EMS. We know that there's all these other steps of getting, doing a patient lookup, figuring out who they are, getting their medical summary, pushing the EMS report to the hospital. My question is, how feasible is it for someone to be able to successfully get outcome data, the step that we've highlighted, without having implemented the other steps in this workflow? So EMS delivers a patient to a hospital. They don't have any interoperability in place at this point. They haven't, they've maybe handed off a paper PCR, or they faxed it to the hospital, whatever. There hasn't been any lookup that's happened to identify the patient. They haven't gotten medical history on the patient or anything else, but they have access to a network one way or another, and they want to get outcome data for that patient. Is that feasible? What hurdles would be in the way, or do they really need to kind of develop this full interaction in order to get outcomes at the end? Thoughts on that?
Yeah, I definitely have thoughts. I think the initial thought is I would love to see the full workflow just because it's better for the patient. But in the absence of that, really working towards, yes, that's possible. They're two separate workflows. They're two separate things. And your technology vendor could offer just a portal to access those networks with those same policy agreements in place for operations data, and not necessarily needing to go the full gamut in terms of requesting and finding the medical summary within the actual treatment workflow. So absolutely, it just gets a little tougher in terms of probably pushing that policy end of things. But once you have access to one, you should have access to most. So it's a little bit more tricky, but definitely possible.
Mario?
Yeah, I think ultimately, yeah, I'll echo a lot of what Matt just said with an additional point that it's all possible. I think it's easily all decoupled. I've seen it all decoupled. The key is patient match and patient identity, right?
Mm-hmm.
If you have the wrong Mario Sanchez my dad's name was also Mario Sanchez, and when we were in the same house, if you type in the wrong date of birth, you're going to get wrong history for that patient. And same thing if you try to look for outcomes for the wrong Mario Sanchez. So, and if you push something to a hospital, and I don't know, his name was Mario Santos or Gonzalez or something, nothing's going to happen, right?
Yeah. Okay. Right. And that's, when you implement the full workflow, you start by identifying the patient, or at least creating some kind of surrogate identifier for this patient that can follow through the process. And when you don't, then you don't have that. So it's one thing for a provider to go into a web portal and try to find outcomes for a patient they transported and search around and put in their name and birth date and encounter date. But for their software to do that for them automatically, that's a challenge, I think, unless you've identified the patient. Okay, well, thanks for the discussion on that. All right, so Lisa will put a link in the chat for the survey for today's task force call. We received a little more feedback than usual last month, so we really appreciated that. I think we had 6 people provide feedback, or 7, yeah. So that was helpful to us in helping to plan the future task force calls. If you're not in the email group, of course, you want to get onto that, so you'll be up to date with future task force call agendas. And then keep following the GitHub repo. I'll add some more content to the wiki after today's call. And then want to get us primed for the call in October. So this will be October 12th, and it'll be getting patient medical history to EMS. So going back up to this workflow diagram, we're going to go up close to the beginning here. We're still not going to really dive into patient identification, but we're going to say, let's assume you've identified the patient and you've searched for medical summaries. Then what data standards and profiles are going to be used for delivering the content of those patients' medical summaries to EMS? Okay, so again, leaving the patient identification question off to the side for just another month, but saying we already know who they are. We're searching for medical summaries. So what standard and profile is used to do that? And we're getting medical summaries back. So what standards and profiles are we seeing being used to get those medical summaries? And then the other piece that's going to be out of scope next month is, from the data that's in those medical summaries, what is it that the software should show to the EMS provider? How should they aggregate and filter and summarize that information? We're going to save that for a future call as well, but just looking at what standards and profiles are used for that piece of the interaction. So if you've got some experience to share with the group from that phase of the interaction, I would love to hear from you between now and next month, so that I can give you a chance to share your experiences on the call, and we'll all learn from each other and figure out that step of the workflow. Okay, so any questions about what we're doing and what's on deck for next month? And any other general questions or comments for the group today before we adjourn? All right. Well, thank you all for your participation today. Great discussion. Thanks to all of those who presented today and shared what's working for them for this phase of the workflow. Yeah, with that, we'll end the call and see you all next month. Thanks, everyone.